Um, can people see? One second.
Oh my God, this whole time I was stalking and I just realized I was muted. But yeah, I said hi to Elton and Rahil. I hope I'm pronouncing it right. If not, just let us know. Yeah, I'm sorry, guys.
Hello.
Hi. Also, Adam, I can only see your Zoom.
Oh, really? Okay, give me 1 second to fix this.
Hi, Parisa.
Hi.
How are you?
How's everyone doing? Let's see here.
Hey guys.
Hi.
So how do I
Present. We can go. You see the right top corner on the other side.
Oh, yeah, I see.
Okay.
Oh, perfect. So,
Hey guys.
Hi.
how's everyone doing? 1 second, I'm gonna turn on my camera.
Hi, Jordan. Hi, Rose. Hi, Charles. Hi, guys. Thank you so much for coming today. I think we should wait a little bit, right?
I think so. Let's give it like a couple of minutes. Yeah.
How is everyone? How are your classes going so far? Any hard midterms last week or next week? Or anything?
Mm-hmm. Yeah, I definitely had one last week. Tuesday. Pretty tough. But tomorrow I have one and then next Thursday as well.
Yeah, me too. I have one on Thursday.
Mm-hmm.
Paras, what midterm did you have so far? Oh, Jesus, yeah, chem exam. No, I can't do that. Oh my God, that's so much. Whenever you need help with any of the exams or like reviewing papers or anything at all, you can always reach out to us. Not that I'm an expert in any of that, because I'm not, but I can try. But good luck. And thank you for joining, even though you have so many exams and papers too.
Yeah. For some, Natalia, how are you able to see the script for?
Oh, you can't see it on the slides when you're presenting, I think. You can try click on notes. Are you able to see?
Yeah, I'm on speaker notes. Do you guys see my notes or do you guys see the screen?
You only see the screen.
Oh, so you guys, perfect.
Wait,
or are you?
see if you can't hear anyone. Let's see. I think, can everyone else hear us?
Yes.
Thank you.
So you guys are not seeing like everything, all the text on my screen. You guys are seeing just the PowerPoint, correct?
Yeah, we just see the PowerPoint.
Oh, perfect. Wow. Okay.
Oh, sorry that you're hearing me type. Stephen, can you hear us now? It's not.
Oh.
Hi guys, thank you so much for joining us today. I know midterm season is tough, but thank you for taking the time and coming to talk to us, and also hear Dr. Peixoto. I'm pretty sure he'll be giving us some great advices.
Absolutely. This is so weird. Just give it a couple minutes, I guess. 2 more minutes, I guess. Can you guys see the notes now, or is that not showing up still?
No, not at all.
Really?
Yeah, it shows you like, yeah, now you're back in the first slide. But yeah, we can't see the notes. That's really cool.
Oh, that's perfect. Okay, wonderful. I just was feeling bad. Like I thought like in the top right corner, it was like my notes and everything. Okay.
Yeah, that's good for me too, because I didn't know that. Like I used to have my phone up right here with all my notes, and I would just read them out loud. But
Yeah, I was about to do that.
I guess I could start now, right?
Yeah, I think so. I think we should. So, all right. Hello, everyone. Thank you for taking the time to come to GBM 4. Today, we are honored to be joined by Dr. Peixoto, an amazing nephrologist at Yale. And before we meet with him, we will start with some updates from the Eboard. Now, Natalia will go in and give us a warm message about the recent news about the virtual spring semester.
Yeah, that's a lot. Okay, so yeah, we wanted to start off this meeting by reading 2 quotes that could maybe serve as motivation for you now or later on. And so the first one says, believe in yourself and all that you are. Know that there is something inside you that is greater than any obstacle. And the second one says, don't wait until you've reached your goal to be proud of yourself. Be proud of every step you take towards reaching that goal. So we think that these quotes are especially significant right now because, like Adam said, kind of like of everything that is going on around us. So not only do we have a lot of college stuff to do, like we're talking about like classes, exams, papers, and other assignments, and even discussion boards, I have a lot. But we also have a lot of labs, clubs, and applications going on, and most importantly, us and our family. So we have to be here for them, and we also have to be here for ourselves. And then no matter what, grades, applications, or whatever, your health and your well-being comes first. And this well-being isn't just your physical health, but it's also your emotional, spiritual, and intellectual health as well. So as you all know, GW will be online next semester, and then most of us will probably continue doing what we've been doing this whole semester and probably staying where we are. I'm doing that, I don't know about other people. But we in the Ampc just wanted to let you know that whenever you want to talk to us through emails, Zoom calls, Instagram DMs, iMessage, anything, or even if you just want to quietly study together, we're always here for you, and we truly mean that. But yeah, that was a bit emotional, but I hope that it motivated you a little bit more. So I guess I'm gonna let Adam speak now. Yeah.
Sure. Thank you, Natalia, for that one message. In today's agenda, we just want to give you an overview of the activities that we've been preparing for the past 2 weeks. First, we'll go over some updates for Ampc Symposium, then our mentorship program. later the Health and Wellness Program, and finally the virtual education opportunities. So to begin with the symposium, now let's move into some updates. So for those who aren't aware, Ampc Symposium is our flagship research program. We set up an independent research teams, pair you with senior members for guidance, and host annual research symposium event at the end of the spring semester, and help you get published during the summer. Ampc Symposium is a year-long project that spans both semesters and even into the summer. Last week, we released a form to sign up for the symposium program. If you're interested in joining and working with a team of students on an independent research, you can fill out the form. We will have the link to the form in the comments section in our Zoom. Research teams are selective due to the limited number of researchers in the program. As we gain more in the future, we will notify you. Now, Victoria and Ishan will talk with you guys about our mentorship program and some updates.
Hi guys. Thank you guys so much for your involvement with that mentorship program. I really enjoyed reading your applications, and it was a long process sorting you guys out, but it's really fruitful for you guys. But yeah, we're finalized. I'm sorry if anyone received 3 emails from me. I was kind of confused if they were sending or not. But yeah, your groups are all in there. It contains emails. Feel free to start reaching out to each other. And yeah, we have our meeting on Friday, and Victoria has an update on that.
Hey guys, so me and Ishan have been working on the mentorship groups and also setting up a meeting for everybody to attend to meet each other and go over some general guidelines for the program. We originally sent out an email that said our first meeting would be at 3 p.m. on Friday, October 23rd, but instead it's going to be at 4 p.m. because some people reached out to us saying that they had class until about 3:30, so we decided to push it 1 hour. Yeah, so hopefully any of you who are involved in that can make it at that time. And we're really excited to meet you all and go over what our program is all about.
Great. So now I wanted to talk a little bit about the Health and Wellness Program again. I know we mentioned it last GBM, but I know that some of you may have not come because of midterms and everything going on. So we created a form. It's not like an interest form, but it's more to let us know when you're available to come into each events you can or want to come. And I'm putting it in the chat right now if you want to fill it out now or later. And then I wanted to explain a little bit why we picked anxiety and depression. So I think that most of us know that anxiety and depression are some of the most common mental health conditions, especially among pre-health students like us. And feeling anxious or depressed every day not only affects our mental health, but mainly our physical, social, and intellectual well-beings. And now in the midst of a pandemic, where it's difficult for most of us to find constant support and being told bad news every day, the tendency for both anxiety and depression to increase is really high. So by creating this program, we really hope that we can all understand the key factors driving each one of our feelings and becoming anxious and depressed, so that we could maybe find a way in which we can all help each other just by talking, by relaxing and breathing, even if it's all online. So we are offering the ability for us to learn a little bit more about these conditions and to be able to talk to one another about any feelings that we might have. If you want to talk about it, you're not required to do so. And so that we could start experiencing or trying to experience a little bit of a sense of safety and calm, which hopefully will benefit our health. And then I wanted to point out that in the 1st of November, we had only Dr. Friedman, who's a dermatologist, coming. And now we actually will be having 2 speakers, Dr. Friedman and Dr. Mortman, who's a thoracic surgeon. They will be speaking for a half hour each. So we'll start with Dr. Friedman, and half an hour later, Dr. Mortman will join us and talk to us about his career. And I know that this is not very much related to anxiety and depression, but we can always ask him questions related to that, especially in the medical setting. But yeah, I think that's it from me. Yeah.
Thank you. So this week, we have some wonderful opportunities for you. We spoke with Kristen Toll, GW's pre-health guidance counselor, and she put us onto a number of different resources that will help you get ahead and be competitive for medical school. The first opportunity is a virtual volunteering with the Red Cross. Ms. Toll emphasized the importance of getting volunteering hours, and further, she said it's important to stick with 1 or 2 volunteering projects if you can. We have more than 25 different volunteering opportunities in our career service drive. We will be showing you an opportunity every meeting, and don't forget to come to office hours, as you can get them all. We also have several resources such as a DO information session hosted with Kristen Toll and the rest of the pre-health committee, as well as more information for pre-PAs and pre-dental students. We have linked all these opportunities in the comments section down below.
Okay, so as we met with Kristen, who happens to be our advisor now, I don't know how that happened, but she's our advisor. She also asked us to talk a little bit about HPAC. I didn't know about it until last year, so I don't know if all of you know about it. I'm gonna put up some links in the chat again about like many different topics that they have, like info sessions, their application, their email, reference documents, info sessions that you have to attend, and read a little bit about what they are, or what HPAC is. So the purpose of the GW's Health Professions Advisory Committee, which is HPAC, is to evaluate applicants under a candidacy for medical and dental school, and then provide a letter of evaluation that could be included in your application packets. So this consists of pre-health advisors and faculty members from the sciences and the social sciences. And then this letter of evaluation is going to be written only after the student completes all of the application requirements, the interview, and also the follow-up appointment that you have to complete. This is not mandatory, but it's really good because it seems that medical and dental schools place significant weight on these letters, and then we recommend going through HPAC if you want and if you're qualified. So you can see the HPAC application in the chat. And then if you're applying to apply to HPAC in 2021, the eligible people are juniors, seniors, and alum applying to medical or dental school. You have to review the HPAC information, which is also included in the chat, to see all the instruction and the supplemental materials. There's also a document with the questions that will be asked on the application. And you can also, you have to go to information session, as I said, which is also in the chat, and the check-in appointment as well. So this is all due January 31st, 2021 at 11:59 EST.
Thank you so much, Natalia. That was really wonderful information. And so before we begin our discussion with Dr. Peixoto, we're gonna have a little bit of a fun game with you guys. It's called Rosebud, and essentially Rosebud Thorn. And essentially we talk about something that happened, one good thing that happened to us this week. It's one thing that bad happened to us this week, and one thing we're looking forward to next week. And we're going to have different breakout groups so we can discuss in smaller sections. And Natalia will be doing that for us right now.
Yeah, I forgot to do it earlier. Oh my God, I'm so dumb.
Does anybody have any questions for us by chance that we can answer? If there are, I can't see the comment section because I'm
No,
the host. Yeah, okay.
If you have any questions that I'll prepare to ask.
Absolutely.
I have a question really fast. So basically the symposium, is it, so it's more so for students pursuing independent research or not currently working in a lab? Is that right?
Yes, it's mostly in, so essentially we want to be able to have students get published on research projects, and the more involved they are, the higher their position on the research project, the better. This is to help, it doesn't necessarily have to be where you're not working at a research lab currently, but if you do have experience with that, I think it even helps more. It's just there are limited positions right now. We want to get everyone a position, but we have to find more senior researchers to join our project. And so that's just why there's selectivity in it. But everyone is welcome to join, and yeah.
Okay, I'm gonna take everyone to the rooms and you can join it.
Sounds good.
Hi guys.
Hello. Sorry, my connection is a little iffy today,
So good.
so I can't have my video on, but
Yeah.
Hi.
Hi. We're doing Rose, Bud, and Thorn, I'm pretty sure. But if everyone just wants to talk about how stressful their week is, that's also okay, because I know I have a really stressful week as well. So tomorrow I have an orgo lab exam that I'm not excited about. I was like studying today during the Giants game, which is actually really counterproductive. Yeah, I didn't understand any of it, so I'm probably going to have to redo that tomorrow. And yeah, I just have a ton of midterms, including like a biopsych, stress and coping, and my second orgo exam. So that's not great. How about you guys?
yeah, that sounds like a lot. I don't really have midterms this week. I had some last week and I have some next week.
Mhm.
But yeah,
Well,
I have papers due,
yeah, I totally
but that's about it.
Yeah.
Mine have been pretty spread out for the most part. I do have a chemistry one this weekend, so that's not going to be fun.
Yeah. What chem are you in?
I'm a freshman, so Gen Chem.
Who do you take it with?
Clements.
Clemens teaches Chem 1? I didn't even know that. Crazy.
She always talks about how she's an organic chemist.
Mm-hmm. She's my teacher for orgo.
Oh, really?
Yeah.
Oh, yeah.
Yeah, she's a nice lady. At least you got McClary. I had McClary for 2 semesters.
Yeah, I went to rate my professor and was like,
It's not
"What's
great.
that?"
Yeah. How about you?
Yeah, she is nice.
Yeah.
I feel like they take like so much time on very easy things, and then when it's like slightly harder, they like rush through it. It's kind of weird. But
Yeah, no, I don't know why they do it. They don't want to see us winning, quite honestly. That's the best way I describe it.
yeah.
Yeah.
And I had like a paper due last week, and that's it. I mean, other things too, but
Okay, cool. How about Abba? Have you
I
talked?
have like,
Mhm.
yeah, I have an econ midterm this week,
Mhm.
so I'm kind of stressed about that because it's like a big chunk of my grade, and I'm not sure if I should opt for pass fail for that one, honestly, because it's an option and it's not even like a pre-med class.
Yeah.
But I have to see how the midterm goes, to be honest.
I totally understand that.
And it's like so stressful because I'm not sure if the midterms get graded in time for the pass fail. We probably will, but like, is it even worth it if I had like a B+ in the class and it's like gonna help my GPA?
I understand.
And then like, that's like that. And then I have like a bio exam next week.
Oh, really? Who do you take bio with?
So that's like pretty solid. I have Brown.
Oh, you have Brown. I love Brown. I had him for my bio one. He was so much better than Doble. I'll tell you that much. You learn a ton more in his class.
I have double.
I have double too.
Okay, I honestly prefer the weekly quiz thing than a midterm, if that makes sense.
Oh, I can understand. I don't know how he's teaching. I just
Yeah, because I think it's online and he wants people to keep up with the material. He does a weekly quiz, and all of those quizzes combine to be like your test grades.
Interesting.
Yeah, so it's pretty stressful because you're always like on your toes, but I prefer that than a giant midterm in one sitting.
I had Doble for bio too. I mean, yeah, I did have from bio too. I remember after the first exam, he didn't have the quiz system because this was still in person. But after the first exam, we were in that big lecture hall, and right after everyone was done, like stress had finally like de-escalated. He was like, "All right, guys, I'm gonna project the right exam answers on the big screen," and we just went over question by question. I could see the souls getting sucked out of people as that happened. He was the worst.
Oh no,
It was awful. But yeah, no, I took Brown for bio one. I remember that his exams are really difficult sometimes, and the class average is always a 60. But I remember I ended the class with an 81, but he curved everyone up 10 points, so I got like an A-. So I was pretty happy about that.
Okay, because he didn't like explain his curve, so I got kind of scared when I didn't do so well in the first test, and then I was like,
terrible. Don't worry. Getting like a 70 or an 80 is good.
Because I did below the average in the first test. I'm like, okay, it's my first actual like big college exam. I'm like, I'm not like too stressed about it. And then now I have like a second exam in his class, and then he has like 2 more after this, and that like makes up like I think 60% of the grade. So I'm like, is it worth even like staying in the class and like watching my grade drop as the exams get harder? But I know how the exams are now. They're like a lot more vague than I expected them to be.
Yeah, exactly. That's kind of how the exams are, unfortunately. But
Vague?
my advice to you is probably like, I don't know, like I feel like classes get a little bit easier. That's not a good thing. The really good quote that I've heard is that as you go along your pre-med journey, is that classes are always going to get harder, but you're going to become so much better prepared that it's going to be easy to you. Because I remember Bio 1 and Chem 1 are like definitely more difficult at the time than the class I take right now, even though they're upper level classes. So I would just say stick with it. Don't get discouraged by one bad grade, because it really doesn't define you as a student. You're going to take a ton of more credits at GW. Don't GPA watch your entire year, because that's going to drive you insane. So yeah, just try the best you can, and just there's always going to be a stabilizing effect. Your GPA will always rebound from a bad score. That's just stuff I've heard from people older than me too.
Yeah, that made it so much better. I was like, oh my god, I got kind of stressed, to be honest.
Yeah, I completely understand. I overreact over like every small grade. You know, the thing I hate about bio the most is the labs. The labs are horrendous. I remember that. In bio 1 lab, I would get like 6 out of 10s on every single quiz. Like no matter how much I studied, I do trash on them. But eventually, like they like curved it, luckily, and it helped me out. But I don't know how that experience is right now.
I can't pity you, because virtual lab is the absolute worst thing to ever be. I think virtual lab is genuinely my least favorite part of virtual school.
Yeah.
Like there's nothing that's as terrible as virtual lab.
Oh yeah, definitely. And it's so long too.
Yeah.
Yeah, and it's, oh my god. I mean, bios at least, I mean, you can't really like do badly on the lab, because it's just like, I mean, you know how it is. We don't get scored on it. But for chem, it's just the worst. If you forget to stir one thing, it's like 10 points.
I know. Yeah. I know. I took bio lab, and I took bio 2 and chem 2 lab online last semester. I remember bio lab was horrendous. I took it with like this woman named Nikki. She was the devil. She would grade my shit so hard. I would get like a 70 on everything, even though I tried so hard on it. Then for chem lab, yeah, like what you said, like you can make the most minute mistake and they take off so many points. But really, it's really all about collaboration at that point. You just gotta work with other people. And that's how I got over it. I understand that's hard as a freshman.
Yeah, it's just like hard to know people.
I'm so sorry. If you ever have the opportunity to take, I know you can't choose your lab TAs, but if you have the opportunity to somehow switch into a class with a guy named Shiv, I've heard that he's by far the best bio TA or graduate teaching assistant. Yeah, he's the easiest grader by far. That's just some advice.
My bio TA is like super easy. I don't know, but she doesn't know what she's doing at the same time either. So it's like a give and take. It's like painful sitting through her class, honestly, because she messes up, but then she posts her PowerPoints, which have her notes, which she just explains in class, and then those notes end up being like the answers to her quizzes. So
that's so nice.
She's like, I'm not gonna try to torture you because I know how hard it is. And then half the time she shows pictures of a pet snake and like.
Wait, who do you have? Do you have Hadil?
Yeah, Hadil.
Oh yeah, I have Hadil too. Yeah.
Was it just me, or you feel like Hadil's kind of a mess sometimes, but she's like super easy?
The thing is, I'm like her first class. Like I'm the first bio class.
Oh no.
They test everything on my like lab, so it's like even more of a mess just because like we're basically the guinea pigs for everything. Yeah, it's weird.
I'm in Hadil's Wednesday night class, so I'm like, this is so much better.
Yeah.
And then she forgets to record your class, and he sends out our class. It's like every single time.
She's really nice though.
Yeah, I love her. She's so sweet.
Yeah.
But she makes it easy. So that's all I care about.
Yeah.
Biolab, you guys have to sit there the whole time or not?
Yeah.
Really? That sucks.
They like the structure is really weird. So we start out with like a presentation and then she'll go over it. Or we have to do problems sometimes, I'm not really sure. And then we do a lab, but we have to like be in class and do the lab, but it's individually. And then we meet again afterwards and there's like some activity or something. And then you do the test.
Oh my God.
You do like the tests and stuff on your own time.
Okay, yeah, that's awful. You guys definitely have it worse than I did. I don't know how you do that. I could not sit in that lab for that long. I would not do it. The thing is, Nikki, for me, she never had any live lab sections. She would just like record something and be like, watch this. But she'd also give us 0 direction on any of the assignments. So we'd all be terrible on it because we don't know what to do.
Yeah.
But yeah, I could not imagine sitting there for 4 hours or whatever, however long it is. I know for Chem Lab last semester, we only had to stay there for 15 minutes and we just did everything by ourselves.
Yeah, they have us do like discussion problems and then she goes over a really short presentation and you're out by like 1:30 if the class starts at like 12:45 or something.
Yeah, that's a nice thing, honestly. You guys probably haven't experienced like Chem Lab at the worst in person. There's times where you will actually have if you think it's just a 4-hour block that's supposed to accommodate extra time. No, sometimes the labs actually go for 4 hours. I don't know how. Like the time just flies by, and you have to do so many things, and you like legitimately just don't want to do anything else for the rest of the day. It's the worst. You guys will have to do that at GW when you get on person.
I mean, not really, since next semester is also online.
Yeah, I guess so.
So we get to finesse that.
That's true. You guys don't have to experience that. It was terrible. Well, it was really nice talking
I was
to you
planning
guys.
to take Chem 1 next semester, so then take Chem 2 outside of GW because Chem 1 is just like hard in GW in general.
Mm-hmm. Yeah, no, it absolutely is. I don't know. Yeah, it was really good talking to you guys.
Yeah.
Have a nice week. Good luck on
Same
everything.
here.
Thank you.
You guys got this. I'll
Thank
see you
you.
guys in the main session. Bye.
Great. So I'll just wait for your cue, and I'll get going whenever you're ready.
Perfect. I think we have about 40 participants, so we can wait a little bit more.
Sure.
I think we have 6 still coming. Okay, good. I think that's it. So hi, everyone. This is Dr. Aldo Peixoto. He's from Brazil, but he's a neurologist, amazing nephrologist at Yale University School of Medicine. And he's here today to talk a little bit with us.
Well, thank you. And thanks everybody for the invitation. So Natalia had asked me to talk a little bit about my career and my experience. She asked for some comments that reflect on my being an international physician practicing in the US. And I'll make some comments about that. But I think that my goal is to just tell you a story about someone who started in Brazil, went to medical school in Brazil, and did pretty well. I think I'm a full professor at Yale, and so I want to tell you some of that story. But I also want to sell a little bit of what I do. So I want to make those of you who are considering a career in medicine to consider following some of my steps. And that relates to a career in internal medicine, a career in nephrology, which is kidney medicine, and perhaps most importantly, a career in academic medicine. So this is what I'm gonna show you. I put together 8 or 9 slides. I'll talk for about 15 minutes or so, and then you can ask as many questions as you want. I don't mind being interrupted. But I can't double task. So I can't look at the chat and talk. So maybe I'll ask Natalia to monitor the chat And if anybody has a question and thinks it would be better to interrupt, feel free to do that, okay? So let me just share my slides. Okay. So this is a part of my my division at Yale. You see me here, and this is about probably 70% of the faculty, and we are the section of nephrology at Yale. I happen to have a role not only in the section where I'm the clinical chief, but I also have a role in the department. And nephrology is a subspecialty of internal medicine. So we sit within a much larger department, a department with about 500 physicians. And that's the Department of Internal Medicine. For that department, I'm the vice chair for quality and safety. So I'm responsible for things related to the quality of care and patient safety in our department. So this is where it started. This is almost 30 years ago. It's hard to believe. I went to medical school in Brazil. You can see and I think they still do this. They wear white clothes, which is sort of, you know, weird the way I look at it now, but that's how people dress. And you can see me up here with that ugly early 1990s hairdo. And when I was in Brazil, my something that you might want to know is that in Brazil, there is no undergrad. So you go straight from high school into medical school. So when you graduate, you tend to be younger than the typical person finishing medical school here, at least by a couple of years. And what I had decided was to come to the US because I wanted to get a greater exposure to a different level of medical care. And I wanted to be exposed to research here with the ultimate goal of returning to Brazil. And then obviously plans didn't work out. I wound up meeting someone who's now my wife during my fellowship, and then wound up going back to Brazil. But that was my initial plan. I think that every time we talk to pre-med students, I think we should always reflect on why we went into medicine. And I'm not going to hide that my interest in medicine started as a scientific interest. I thought that the science was really cool. And that's what attracted me to go to medical school. My father is a physician, and it wasn't hard to transition my interest into that. And I really don't remember for how long. After I noticed that I couldn't be a professional soccer player, which was around, I don't know, 5th grade, becoming a doctor became a natural interest for me. So I think that the main change, and I suggest to you that you always ask yourselves, why is it that you want to go into medicine? And the big transition that happened in my life was one of first being interested in the science to then being interested in the patient. And because when you do it that way, you change your approach to medicine. It becomes more one of building relationships, looking at medicine not only as a science, but as a profession that has a very strong social construct as well. So, and this happened over my career. This was not something that was very obvious to me when I chose to go into medical school. Then I wound up coming here, and I went to the University of Connecticut to train in internal medicine. Why internal medicine? Well, internal medicine is the most cognitive of the medical specialties. I'm decent with my hands. I'm not great. I don't think I would be a great surgeon. And like I just told you, at that time, I was interested in the science, and the science of medicine really is best served in, I think that internal medicine is really the specialty that encompasses the most, because it is largely a cognitive specialty, similar to what pediatrics is if you decide to take care of children, similar to what neurology is, but neurology is it was too circumscripted to me. So internal medicine is the broader. So I went to UConn, a very large program, about 120 residents. And when I started, I was deciding between, I really liked cardiology, I liked pulmonary medicine, critical care, I liked nephrology. And then during my fellowship, my residency, it became clear that nephrology was my interest. I thought, again, it was a very cognitive specialty. So after a year as chief medical resident, I started a Nephrology Fellowship. So let me tell you a little bit about chief medical residency. And that has to do, for someone who comes from abroad, it's something that helps differentiate you a little bit. It's not a position that you just do. It's something you need to be invited to do. And I thought it would be very important in building my credentials. Now, you guys, even those of you who are foreign born, you are not going to be foreign medical graduates, because if you stay in the US after you graduate from GW and you go to a US medical school, you will be a US medical graduate, even if you're not a US citizen, or even if you are not a permanent resident. Whereas if you're an American citizen or an American born, but you go somewhere else to a different country, then you are a foreign medical graduate, just like I am. So these were my 6 co-chief residents, and I wanted to show you just to see the breadth of what people do and what they choose to do as a career. So for example, this guy, Mark Mancini, is a private practice nephrologist in Rhode Island. And then there are 2 other people in private practice. So Ransom Odd is in internal medicine in New York, and Ron Raymond is a cardiologist in Connecticut. Then there are people who decide to go into administration. So for example, Scott Wolf is the COO of a relatively large healthcare system in Southern Florida. And Reza Mansour went into a large hospital system, and he's a cardiologist in the Hartford Health. And then some go into academia. So Doug Robertson is a gastroenterologist at Dartmouth, and I became a nephrologist at Yale. So lots of options. So in nephrology, what can I tell you about nephrology? This is the logo of the American Society of Nephrology, and nephrology is kidney medicine. After 3 years of internal medicine, we go into a fellowship, and that fellowship can be, the minimum is 2 years. Many people do 3 years, which usually includes a research year. Some people stay for 4 or 5 years doing a research component until they go on to a permanent position somewhere. The nephrology, and why isn't this moving? Okay, so nephrology has several components. So from a clinical perspective, we take care of people who have acute kidney failure. That's a large chunk of what we do, and these people are typically in the hospital. We take a lot, we spend a lot of time taking care of people who have chronic kidney disease of any cause. And as kidney function decreases, we become important in sort of managing the complications that can come along with decreasing kidney function. We manage electrolyte disorders, so volume disorders, sodium disorders, potassium disorders, acid-base disorders. Those fall in the hands of nephrologists, and they are really cool to manage. There's a lot of physiology built into this, and about 100 years of research that have culminated in a very substantial understanding of the molecular mechanisms of these electrolyte disorders that are really fun. Hypertension belongs, people often don't know that nephrologists are big in hypertension, but we are. So hypertension as a subspecialty typically belongs in the hands of either nephrologists or cardiologists. I happen to be a hypertension specialist. And then when kidney function fails and people go on dialysis, we take care of them. And when they receive a kidney transplant, we also take care of them. We don't do the surgery, but we take care of their medical care after kidney transplantation. And sorry if you hear my dog barking, little dog, pain in the neck. So we, here I'll show you just a few pictures to give a sense of what we do. So for example, in taking care of patients, here we can take care of dialysis patients. This is someone receiving something called hemodialysis, which is the most common type of dialysis in our country. We can take care of people who have dialysis through their abdomen. It's called peritoneal dialysis. So this is a catheter sticking out here, and fluid is exchanged, and the peritoneal cavity serves as a membrane that allows us to filter the toxins and other substances that need to be removed to treat kidney failure. This is kidney transplantation. As I told you, we do not do them. Transplant surgeons are the ones who do them. But this gives you a sense of how things are done. So a kidney is taken out either from someone who has died or from a living donor. This one is from a living donor. The kidney comes out and then comes out here through what we call a phenosteel incision. This is the same incision that we use for cesarean sections. And the kidney comes out this way and goes into the recipient, not in the position of the kidneys. So these are the normal or no longer normally functioning kidneys. We don't take them out. We just put the new kidney to solve the problem right here in the iliac fossa. Easy to reach, easy to put in. It's a very simple procedure. Taking the kidney out is a bigger procedure than the transplant procedure itself. And nephrologists do a couple of procedures. Some nephrologists put these peritoneal catheters, some nephrologists create fistulas, but what most nephrologists do, and that's my case, we put catheters in. So these are catheters for dialysis. This is the neck of so the head of the patient's here. This is the chest. We're putting a line in the internal jugular vein. So this is essential to do dialysis acutely for people who come into the hospital. The other procedure that we often perform is a kidney biopsy. We do it through ultrasound. We use a needle, go through the back of the patient to take pieces of the kidney to give us diagnostic information. Okay, so this gives you a sense of what it is that we do. And there are some people who decide to go into research, and people who go into research can choose within any of those areas of nephrology. They can study. And some of the current hot topics I list here in basic research. There's a lot of interest in understanding better the molecular mechanisms of diseases of the small compartments of the kidney, such as the glomeruli or the renal interstitium. So understanding these inflammatory diseases has an impact, has importance to the development of treatments. There's a lot of interest in molecular targets for therapy in the nephritides. Nephritides is the plural for nephritis. And also for hereditary diseases, especially polycystic kidney disease. There's an interest in vitro organogenesis, so creating kidneys in vitro, and that has not been an easy feat. It's actually been very, very difficult. It's a lot easier to create an organ. For example, urologists have been quite successful in creating bladders and even 3D printing bladders, whereas creating a kidney has not yet been possible. Xenotransplantation and immune tolerance is a very hot topic because there are too few kidneys to be given to people with kidney failure. So we need to increase the supply of organs. And one of the valuable ways will be to have better ways to induce immune tolerance, but really to make organs available, we need to find something that's either creating organs or transplanting organs from other species, and the pig seem to be the best of animals, and xenotransplantation is a hot topic. And finally, creating new ways to deliver dialysis, and nanotechnology for dialysis is a hot topic in basic science. And then in the clinical and translational realm, then there's some things. So for example, understanding how the kidney is functioning in real time is really important in patients who are hospitalized. So real-time measurement of glomerular filtration rate is a very hot topic. And then a variety of clinical trials in acute kidney injury, in diabetic kidney disease. Diabetes is the most common cause of kidney disease in this country, the different inflammatory nephritides and inherited kidney diseases, lots of clinical trials in those fields. Now that, pretty much every place has an electronic medical record, we're trying to figure out better ways on how to use the electronic medical record to deploy, to perform pragmatic clinical trials, save money, get more direct information doing these studies. And finally, the kind of boring research, but that is tremendously important, is implementation science. So we know how to treat hypertension. We know how to treat chronic kidney disease, at least to slow down the progression, and yet only a fraction of patients have received the appropriate treatment. So the implementation of these well-established treatments is a very important element in improving public health. So let me tell you a little bit about what I do. This is me about 20 years ago. And people who practice in academia have this, possibilities. They can be clinicians, they can be educators, they can be investigators, they can be administrators. And I've done all four of them, and my career morphed over the years. Some people never change. So my father has been an anesthesiologist for almost 50 years. His practice is essentially the same, right? The technology changed, but he goes every day to the hospital and spends time in the operating room pretty much 5 days a week. He has just decreased because he's now older and works only, 4 or 6 hours a day. But the type of work is exactly the same. Whereas my work I've been fortunate to have had a lot of variety over the years. So I started in 1998 being mostly a clinician and about the 20% investigator. But my job was really as a clinician. I went to, saw patients in the office most days of the week. I saw patients in the dialysis unit, and I was the attending physician in the hospital. That was most of what my job was. About 20% was in research. Now, as time passed, I had some other changes. So for example, in 2004, and from 2004 until 2014, I was the director of the renal course at Yale. So that took up a good amount of my time. And then in 2008, I became responsible for one portion of the internal medicine clerkship. So then at one point, education was 30% of my life because I was responsible for the third year medical student clerkships, and I was responsible for the renal course. So that was a huge footprint that was very intense and rewarding. But then after that, after I changed jobs and became more of an administrator, as you can see here, my footprint in education went down. So now my involvement in education is simply supervising renal fellows and residents in the hospital. That's my educational job. I don't think curriculum. I'm not the director of any course. I go there and give lectures as needed. But when I say here as an educator, it's like a formal educator, and that I did for about 10 years quite intensely, but now is no longer a big part of my life. So you see that there's a lot of variety and things morph over time. So this is me now. And I wanted to just give you a taste. This is my schedule for last week. And I hope that this will entice some of you to actually consider following a career in academia. So I start every day with morning safety report. And that's a 15-minute meeting where we hear about quality and safety problems across our health system. There's about 150 people calling into this meeting. So very important for my job as the vice chair of quality and safety. Here on Monday, I started out with a meeting that was directed at discussing how we're going to reframe our telehealth services in our department. Then at noon, we had a faculty meeting where we presented the state of the department. So our chair presented the state of the department, and each of the vice chairs had information to present in their field. So in my case, quality and safety. Then I went and saw patients in the afternoon. Okay, so a regular doctor day. On Tuesday, I start out with a faculty meeting for nephrology where we present the state of affairs, me and the section chief and the clinical chief, Dr. Steve Somlow. So we presented the state of the section. Later in the morning, MCIC, I had a meeting with MCIC. MCIC is our insurer. We are self-insured for malpractice. It's a consortium of Yale, Johns Hopkins, Columbia, Cornell, and the University of Rochester. So we spent 2 hours discussing ambulatory safety issues with the goal of mitigating, obviously improving patient safety and mitigating risk. Financial liability. Then I had clinic again in the afternoon, and I finished the day learning from a physician in North Carolina who's a leader in public policy about new changes in payment models for dialysis that we need to implement into our service. Then I started Wednesday talking about the provider experience. So now looking, we are very interested in patient experience. We're also interested in how our physicians experience care. And we are, Claudine is a consultant with us, and we meet every week to discuss a series of projects that we have in improving the quality of the experience of our faculty. Then we had a leadership meeting, which is the leadership of the department for COVID. In case you haven't heard, COVID is back. And back in the spring, we had these meetings daily for about 2 hours, weekdays and weekends. Now we are back. This was the first one because of a more recent surge in Connecticut. And these meetings are now happening 3 times a week. And let's see how it goes. And I had a meeting about how to teach quality and safety to other faculty. We're developing a course for that. And then I saw patients, but instead of seeing patients in clinic, I saw patients via telehealth. So you get the sense, I go from one thing to another. And then to end the week, I'm going to skip Thursday, but I'm going to tell you to end the week, we are in recruiting season for our fellowship. So I had the chance of not only having our weekly conference, but also I had the chance to meet with 4 candidates during our interview session. So that was a great day. On Friday afternoon, I wrapped up. I called some patients and called it a day at about 4:30. All right, so some lessons from a foreign medical graduate. There's a couple of things that I want to tell you. So you're all going to be U.S. medical graduates. So respect the FMGs, the foreign medical graduates. Their obstacles are often enormous. Remember that when they are coming here, nobody has the slightest clue of what their medical school is. They could have been the top student of the best medical school in Brazil, and nobody would know what that means. So their obstacles to come here are enormous. So respect it. They bring skills and experiences that often enrich in our practice. They've been exposed to different approaches to care. They've been exposed to different methods of approaching patients. They often have had less technology, so they have honed their skills in the history and the physical examination that we can learn from. So respect them for that. And then finally, recognize they are just as smart as anybody from here. So, and that's sometimes lost in the environment in this country. And finally, take some examples, and I think that that's important for us, foreign medical graduates, and for you, not as foreign medical graduates, but to think about the importance of giving back. And I think that that includes things like the care of undocumented immigrants, including political activism to make that an option. At Yale, we are committed to the care of the underserved. We are committed to the care of the undocumented. We are committed to providing free care when free care is needed. And we are the major provider of that in the, especially to the inner city in the New Haven area. And we're very proud of that. We take care of a lot of very wealthy people, but we take the very same quality, we provide the very same quality of care to the destitute and the undocumented. And also think globally in terms of capacity building. Yale has a very strong commitment to global health, and we have joint initiatives for capacity building in several continents, most prominently in Africa. We have some very nice relationships with Uganda, Rwanda, and South Africa that we're very proud of. And finally, get back to my group. So find your passion, find what you really like to do it well, and find a family. And this has been my family for almost 25 years, and I really have a great time going to work every day. And don't forget that it's not only work, you got to do other things. And I'm a lousy guitar player, but I'm a lot better. This was about 1990, 91, I don't know. I'm a lot better 30 years later, but it's still something that I really enjoy in a group that's been very eclectic. Our drummer is a behavioral economist, spent some time at, a lot of time at Berkeley, and went back to Brazil a few years ago. Our bassist is an MBA who owns a mineral water company. And finally, our keyboardist is a corporate lawyer. So we had a good time back then, and I still have a great time with my guitars. And those of you who play know how important it is to spend time doing that. So between my guitars and golfing, which I'm also lousy at, I try to spend time outside of medicine. And in golf, it's my eternal search to break 80. And I thought I almost did it a couple of weeks ago when I shot a 39 in the front 9 and then butchered the back 9, finished with an 86. Those of you who golf know what that means. So thank you. I hope you enjoyed this, and whatever you want to ask, I'm up for answering.
Thank you so much, Dr. Peixoto. That was really, really enlightening. Thank you. If anyone has any questions, feel free to shout or text in the chat. I didn't want to be the first one to ask, but I have a question that it might be useful for all of us. We're just talking in the beginning of the meeting about how we're all overwhelmed with everything going on, not only the pandemic, but also our personal lives. And we have so many midterms coming up and papers and like many more assignments that we usually have. And I was wondering if you have any advices for all of us to not stress out too much maybe, or anything that we could do to lower this.
Yeah, so that's that has a lot to do with resilience, right? So for those of you who don't know, so resilience is the property of bouncing back from adversity. And I would be lying to you if I have experience thinking about resilience from the student perspective, but the concept is the same. And we've spent a lot of time thinking about resilience for our doctors, both our trainees and our staff. And there's certain things that you should use very actively. So first of all, you can't lose track of your sense of community. You find joy in life by having a sense of belonging, by having a sense of agency, a sense of some form of control. So it's very important that I can imagine, or maybe I can't, although my daughter is a sophomore in college as well, how difficult it must be for you guys with having less ability to interact with the class at large. But try to keep as much contact, share your experiences, continue to do things that are important to you. You know, the example that I gave about guitar and golfing. So don't forget that life outside of your studies does not end. And sometimes it's important to be very, you know, with this concept of mindfulness. So how can you be there in the moment and enjoy it? So take time, take breaks. Don't you know, that cramming competitive thing is very difficult, and I really don't envy you guys. I wouldn't like that part. I wouldn't like to go back 30 years, but you should remember that there's more to life than just your studies, and you got to take some time to keep some balance.
Thank you. That's very insightful. Thank you so much. I see a question in the chat. I don't know if you see it.
What do you feel? What do I feel the future of nephrology will be? So nephrology is a subspecialty that has had a tremendous development in the basic sciences for the last 50 years. Okay, we understand to an agonizing detail how the organ works, how the organ stops working, and how injury to the organ happens. We have devised loads of therapies that address these mechanisms, but they have been not very successful in the translation to therapy. So so things that work in different animal models have not worked as well in the clinical space. And we have been, you know, in the last 10, 15 years, while oncology took, like when I was a resident 25, 30 years ago, cancer was a terrible thing to have. I'm not saying that it's a good thing to have, but oncology has really soared in terms of identifying new treatments. So we, and you know, cardiology was in that situation a few years before. And so when you look at the availability of options and clinical trials to deploy these options, nephrology falls fairly low compared to these other specialties. So what we are very optimistic about is that we know what the targets are, and we are now seeing a significant growth in the treatments that we can offer. So for example, our clinical trials unit about 5 years ago was offering 3 or 4 trials. Now we offer 15 or 17 trials for a variety of different diseases. So if you come to us, we're going to be offering you stuff that's completely new. So what do I feel the future of nephrology is? That we're going to be able to slow down or cure some of the chronic diseases, that we're going to be able to, for those people that we cannot save the kidneys, we're going to find better ways for people to have transplants with less need for immunosuppression and broader delivery of transplants by, in the short term, xenotransplantation, in the longer term, organ creation. The organs are not coming anytime soon. Xeno would not surprise me if is in the 5 to 8 year horizon. I hope I'm right. How is being a doctor in Brazil compared to being one in America? Which was better in your opinion? So one disclosure, I was a resident for 2 months until the match came out. And that's the extent of my practicing as a doctor in Brazil. I never went back. Then, after I matched here, I dropped out and came here to train. So my experiences are through many friends, my years in medical school, and my father, who's a practicing anesthesiologist. There are many differences. There are some that are purely technical in terms of availability of resources. In Brazil, you can have care as good as anywhere in America. So if you go to Albert Einstein, which is a hospital in Sao Paulo, you're going to receive as good care as if you walk into Yale New Haven Hospital, which is one of the top 20 hospitals in the country, in this country. On the other hand, the average Brazilian is probably going to go to Brazil has a public health system that is unfortunately grossly underfunded. So you're going to go there and not receive a quality of care that would be the same as that delivered at other places. So point one, gigantic inequities in accessibility to care. The second one is in terms of training. In Brazil, and don't quote me on these numbers because I don't have the exact numbers in hand. But in the US, after you finish medical school, you pretty much just don't do a residency. If you don't want to do a residency, you want to have a career in let's say you can be an MD, JD, and you decide to be a lawyer, not a doctor. You can be an MD, MBA, and you decide to be an entrepreneur rather than a physician. Or you want to be or you may be an MD, PhD, and decide to be a pure researcher. But people who want to practice and learn to practice medicine, everybody has a residency spot, unless they don't qualify, and that's a very small percentage. In Brazil, there's only about 50% capacity or something along those lines. So if you have however many, 10,000 graduates a year, only 5,000 will have access to a residency. Now that's a major problem because someone with just an MD cannot practice medicine. You do not know enough to take care of people. But unfortunately, that is something that happens there. So a lot of these graduates end up going to, they may go into the armed forces, they may take some jobs that provide general medicine care in a way that significantly concerned me. This was my mother. Do you guys ever watch that Geico commercial that says mothers always call you at the wrong time? Yeah, they always do. She has a knack for doing that. So that part of physician training is a significant difference. Another one is one of role of the patient. So what do I mean? Here, the role of the patient and role of the physician in the care. Here, if I order a test, it's my responsibility to receive the result and act on it. In Brazil, you go for the test, you pick up the results, whatever that is. It could be a blood test, it could be an MRI, it could be a chest x-ray. You go, you pick the results, you pick the films or the DVD, you pick up the report, and you bring it back to the doctor. Now, imagine if the patient, you know what, I'm not going to bring this back. And then I'll take my MRI back 6 months later. And oops, you had, let's say the MRI detected a lesion that's consistent with let's say a kidney cancer. And by the way, maybe 6 months or a year will make a difference. And that is completely unregulated. I find that very troublesome, and it still is the reality in Brazil. And I could sit here and list a lot of other differences, but these are 3 or 4 that come to my mind right now. Oh, someone really likes the commercial. And someone is sharing that that some of the things that I said are the same when Adam was in China. So again, I'm gonna start fighting with the guys coming out of the helicopter. What is the best piece of advice for college students wanting to revolutionize medicine? Can you be a little bit more specific, Stephen? There are several ways to be disruptive. Where's your passion? Is your passion in research? Is your passion in care? Where do you see yourself revolutionizing? And then I'll give you a... Mãe, eu tô dando uma aula, mãe. É emergência? Tchau. Tchau, tchau. Tchau, mãe, eu tô dando uma aula. Sorry, you heard Portuguese. So researching regenerative medicine, great. So then you have, so regenerative medicine is directly applicable to nephrology. Why? Because different from someone who comes in, let's talk about, for example, infectious diseases. You come in with COVID, okay? And you have a huge inflammatory response to the virus, and you develop acute respiratory distress syndrome, and everything goes awry. The way to address that is completely different than when someone comes to me with already established kidney disease. You could have kidney disease for 5, 10, 20, 30 years, completely without symptoms. And then you show up in my office, someone finally checked some blood test and found that my kidney function is now whatever, 30% of normal. And at that time, if you've had a slow progression, I'm not going to be dealing with inflammation. I'm going to be dealing with fibrosis. So now the approaches are completely different. So a very important, I didn't put it in the hot topics, but a very important area of research that applies to nephrology, applies to cardiology. So for example, heart failure, applies to lung disease. There's a large group of lung diseases called interstitial lung diseases or fibrosing lung diseases that looking at ways to reverse fibrosis becomes a very important topic. So regenerative medicine has a significant role there. Then there's also the coolest thing, which I think is really regenerative in a preventive way. So how do we prevent aging, right? How do we make ourselves, how do we get to the point that we can actually live for longer than 115 or 120 years? Because right now it's not possible. And so that is a tremendously important area of research. So what piece of advice? look where you want to be, and pretty much at just any geographic area in this country, there will be people doing pioneering work. Find an area that is of interest to you. Look for the right people. Look for the right mentors. The right mentor is not necessarily the most famous investigator. The most famous investigator with the largest lab will have 20 projects going at the same time. And if your project is just one of those 20, and the investigator will really give importance to the 2 or 3 that are successful. And if you're not in the 2 or 3 that are successful, you may not do as well. So it's a fallacy to think that going to the biggest lab, the biggest name is the right thing. You need to go to someone who's very, very strong, but who's going to have time to mentor you so you can grow. I think that that's a very important piece of advice in research. I really lucked out in the mentoring that was given to me, and I have over the years I've precepted, I trained a little over 30 trainees that did research with me, and I'm going to tell you, early on I was a much better mentor. There was a time that things started getting so busy and I had 5 people working with me and I was busy with my own work that I started saying no to people that came to me because I couldn't deliver on my mentorship. So have these very candid conversations with anybody you decide to work with.
I see another question.
Oh yeah, I was just gonna say I put my question in the chat. Thank you so much for sharing today. But I was just wondering what some of the factors that were determining for you to transition from the more clinical side of medicine into academia and also administration.
So academia was always my choice. I really never saw myself in private practice. And the reason is because I like to learn so much from my patients, and I like to deliver care that is, I don't want to brag. I don't want you to get the sense that I think I'm better than anybody else, but I want to practice in a place where people that others couldn't figure out come. And that's what I do. I take care of very specific people. My area of expertise is hypertension, but it's not hypertension like my mother has that anybody can treat. It's hypertension that the cardiologists can't figure out. Then they come to me. And I take care of something that's called cardiovascular dysautonomia. So these are syndromes of dysfunction of the autonomic nervous system. And I love to do that because it takes time to figure it out. And often others just can't figure it out. But with that, my brain has limited bandwidth. By the time I've seen 8 or 10 patients in a day, I'm done. I'm toast. I can't be like some of my one of my colleagues was chief resident with me. He's in private practice. He sees 30 to 40 patients a day and loves it. I would die if I saw 40 patients a day, 5 days a week. So I only like to see, no more than 6, 8, 10 patients, no more than 3 days a week. That's what I like to do. So it became very, so when people approach me to have a larger educational footprint, I accepted it. And that educational footprint came with a caveat. So when my chief of medicine came to ask me to be the director of inpatient services in 2008, I said, he sold it to me by saying, you're going to teach the medical students, you're going to be responsible for the medical, for the 3rd-year clerkship. You love it, you do it so well, you're going to do great. What he didn't tell me is that there was going to be an administrative component to it. He said, oh, that's going to be nothing, don't worry. As it turns out, it turned out to be a large administrative component. And what really surprised me was that I liked it and that I actually did it pretty well. So all of a sudden I started saying, you know what? It's cool to have a footprint that goes beyond the individual patient and turns into the footprint of the division, the footprint of the department, the way we deliver care, the way we provide innovative care. And those were things that interested me. So for example, take telehealth. I had been working on telehealth for years and I couldn't get anything to happen. Then what happened? Something called COVID. I don't know if you've heard about it. And all of a sudden, telehealth became, sort of everything that I was preaching for years became the obvious. And those things are fun. So it's how, it's what ticks you. And sometimes you can't be afraid of getting exposed to something new, taking a new challenge. And I like to take new challenges because I don't like to do the same thing for too long. Adam, I think I probably answered the what is it? How does it feel to be both a physician and administrator?
I do have another question. Sure. Essentially, you said that you were on the board for for residencies, like deciding who's going to be a resident at the program. What kind of things really help a medical student stand out for a residency in nephrology? Yeah.
So a step ahead, not only what you're doing now, thinking of getting into medical school, but at the end of medical school, going into a residency. That varies substantially according to what subspecialty you're going to go into. So let me answer that for medicine, okay? The first and most important thing is you need to try to decide during medical school, where do you see your career? Do you see yourself as a private practitioner? Do you see yourself as someone who wants to go into public policy? Maybe you want to go for CMS. You may want to go work for CMS or for the CDC. And then the last one, there's a lot of people who are undecided, who all they know is that they want to have great clinical training. And then they end up saying, I'm going to go work at a place that can offer me different options. So first thing, you need to know what you want. The programs are going to want, especially the strong programs. I trained at UConn, which is a strong second-tier program. Okay, it's a very good program, but it's a second-tier program. At Yale, we have a strong first-tier, top 10 internal medicine program, number 9 on US News and World Report, whatever if you decide to look at it or not. So at Yale, we are interested in medical students who are above all committed to patient care. People need to like to take care of patients. It's a necessity. We even though we love to attract physician investigators, we actually have a pathway. We have a physician investigator track. You do only 2 years and then transition straight to a laboratory. We love to attract that. We need to have everybody with a commitment to enjoying taking care of patients. The second one is, we like people to, as I told you, Yale is committed to the care of the underserved. And so we want people who think in a way that favors that. So for example, we love to recruit patients students who have an interest in global health, for example. So a large chunk of our residents go on global health electives. So they go spend 6 weeks, 8 weeks in Uganda, Rwanda, one of our 2 programs in South Africa. We want that engagement. We want to see people who have done during medical school, who have participated in free clinics. student-run free clinics. So those things are very important. And obviously, it's great if it comes with some scholarship, right? If you're able to do some scholarship, that's very well received, because as you may know, for those of you who have looked at the Yale School of Medicine, we actually have a thesis requirement. So all of our, it's part of the requirement to graduate from medical school. So that part of self-propelled scholarship is an essential component of the Yale system, and that does get translated into the different departments.
Thank you so much. That really answers my question very well. Thank you.
So, well, if there are no more questions, let me tell you, I really enjoyed doing this, and I wish you all the best of luck. And if you'd like to contact me, I had put my email, aldo.peixoto, PEIXOTO@yale.edu. Okay, so it was a pleasure spending the evening with you. Take care.
Thank you so much, Dr. Peixoto. We really appreciate it. I know that we learned a lot from you, so thank you so much for coming. And I'm going to even paste your email in the chat in case anyone wants to contact you soon.
Very good. Feel free to do that. Take care, guys. Good luck.
Thank you so much. Stay safe. Good luck. Thank you. Bye.
Thank you.
Thanks so much for coming, guys. If you have any questions, just let us know. You can always email us or DM us or anything. Thank you so much. Good luck with all your stuff, not only midterms, but everything else, because there's a lot. But yeah, you got this. If you ever need help, we're here. Not that we can help much, but we're here. But yeah.
Absolutely. Thank you guys for coming, and we're so excited to see you at our next events. We have a lot of good things coming up these next 2 weeks, so we're looking forward to seeing you there.